Chapter 14, Care of Patients with Disorders of the Lower Respiratory System. Chapter Objectives. Clinical objectives. Symptomatic treatment will include humidification using either warm or cool, moist air. Cough suppressant or bronchodilators are useful to reduce cough and soothe the irritation in the tracheal and the bronchial mucosa. Nutrition and fluid balance need to be maintained. Rest is recommended to prevent progression from an acute condition to a chronic condition. And if the sputum culture identifies a specific bacterial organism, then an antibiotic will be provided. Between 9 and 36 million cases will roughly result in 140,000 to 710,000 hospitalizations yearly and will cause between 12,000 and 56,000 deaths each year. For influenza, the inflammation may involve the lungs, the pharynx, the sinuses, as well as the eustachian tubes. The damaged tissue will provide an environment for the growth of the bacteria that can cause a secondary infection. The virus is usually shed for 1 to 2 days before the onset of the symptoms. Diagnosis is usually based on clinical findings. To confirm the diagnosis, viral culture, serology, rapid molecular assays, or rapid influenza diagnostic tests that are an antigen detection assay can be used. Immunofluorescence assays are another type of diagnostic test. Antibiotics are not effective against a viral illness, therefore they are contraindicated. Antiviral drugs must be started within 48 hours of the start of the symptoms. Some nursing interventions for individuals with the flu may be increase the oral fluid intake to at least 3,000 milliliters per day. Encourage the patient to take some analgesics when they first discover these discomfort and the symptoms. Saline gargles are effective for a sore throat. Administering a suppressant cough medication at bedtime and during the night. Performing oral care at least every 4 hours before a meal, and more frequently if the patient might have a bad taste in their mouth or they may have halitosis or bad breath from the sputum. We need to make sure that patients' food and drink preferences are catered to within their limits for their diet. We will give antipyretics and use cooling measures to decrease a high fever. Air needs to be humidified. Patients need to splint their chest and their abdomen with a pillow during coughing attacks. Sometimes an emollient will need applied to the lips or the nares. Clearing the nostrils as much as possible to help prevent mouth bleeding. We need to make sure that they have periods for uninterrupted rest, and we want to try to help teach them frequent hand hygienes to protect them from secondary infections like pneumonia, otitis media, and sinusitis. Pneumonia is an extensive inflammation of the lung with either consolidation of the lung tissue as it fills with exudate or interstitial inflammation and edema. It can affect one or both lungs. One lung is most common. Lobar pneumonia is a serious condition that infects the entire lobe of the lung and is usually caused by Streptococcus. Pneumonia can be classified as community-acquired or hospital-acquired. Viral pneumonia does not produce an exudate, but it will cause interstitial inflammation, and it tends to be less severe than bacterial pneumonia. Atypical pneumonia, also known as walking pneumonia. The body temperature may be normal or below normal. Breath sounds may be normal with maybe a slight crackle or wheeze, and there may not be any pleural involvement, thus no pain, dry cough, or feeling of fatigue. Patients that are at risk for healthcare-associated pneumonia, these are at-risk circumstances where the symptoms occur more than 48 hours after admission, or ventilator-acquired pneumonia, where the pneumonia will occur 48 to 72 hours after endotracheal intubation. Typical pneumonia may be treated with IV or oral antibiotic agents, erythromycin, Biaxin, which is a macrolide, cephaloflurins, fluoroquinolins. Atypical pneumonia is usually treated with erythromycin or azithromycin. Viral, which is an atypical pneumonia, routinely requires no anti-infective therapy, but antiviral medication may be administered. Pneumocystis jirovecii infection is associated with AIDS or acquired immunodeficiency syndrome. This is treated with trimethoprimsulfamethasone, which is Bactrim. It is usually given either IV or orally. That depends on the severity of the infection. The first sign of decreasing oxygenation for the patient may be restlessness or confusion. The patient may want to sit upright to get better chest excursion. The respiratory rate will increase, and later there may be flaring of the nares, then retraction of the intercostal muscles if the condition worsens. Cyanosis for patients that have pneumonia is a very late sign. For atelectasis, deep breathing and the use of an incentive spirometer help to keep the alveoli open and functioning. If the postoperative patient has crackles in the base of the lungs, as a nurse, we have them take several deep breaths and cough. We will auscultate their lungs again. If the crackles are gone, then the atelectasis has been cleared. Fungal respiratory infections like blastomycosis, cryptococcus, Candidus are usually seen in immunocompromised people or those that have cystic fibrosis. Routinely, there are no symptoms or may present with mild respiratory symptoms, but 40% may have a cough, fever, pleuritic chest pain, myalgias, and arthralgias. Sometimes there may be a flat red rash with dark red papules. Latent tuberculosis infection refers to an infection with Mycobacterium tuberculosis, but no current active tuberculosis disease. Latent tuberculosis may develop into active tuberculosis if the immune system is weakened by a serious illness such as HIV, or when the system is maybe not as efficient, thinking about older age. Tuberculosis is spread through airborne particles that carry the tuberculosis bacilli and then are inhaled by a susceptible individual. The droplets may remain suspended in the air for several hours. Mycobacterium is an acid-fast, aerobic, slow-growing bacillus. When the organism enters the lungs, a local inflammatory reaction happens, usually in an upper lobe. It can take 2 to 12 weeks for the organism to replicate in sufficient numbers to prompt enough of an immune response to be detected by a tuberculosis skin test. The onset of TB is routinely gradual. A patient may have an active progressive lesion before symptoms actually appear. The early detection of tuberculosis is vital because anti-TB drugs are more effective in early stages. The period of disability will be much shorter. This decreases the amount of complications, and we can prevent the spread to other individuals. Skin testing for TB is done by the Manitou test. In this test, 0.1 mL of purified protein derivative, tuberculin, is injected right under the skin intradermally. The test is called the tuberculin skin test. The test is positive when swelling at the injection site is more than 5 millimeters in diameter 48 to 72 hours after the injection has been received. There are 2 specific blood tests that are approved by the FDA. One is the quantiferon TB Gold test, and the other one is the T-spot TB test. These tests are interferon gamma released assays that measure the patient's immune system reaction to tuberculosis. These tests do not distinguish between active and latent tuberculosis. A diagnosis of active tuberculosis is established when the tubercle bacillus has been found in the sputum or gas. An effective cure for tuberculosis can be obtained within 6 to 9 months for most patients. The drugs are given in varying combinations and various days of the week. Treatment protocols outline the initial 2-month phase, followed by different options for the continuation phase of either 4 months or 7 months. Some patients do not want to comply with their course of medication. So in that instance, we recommend that we use direct observed therapy. Then we will visually see the individual take each dose of the medication, and oftentimes this will use a health nurse, a public health nurse, or a clinic nurse. Doses of vitamin D have been found to be successful to help prevent and treat tuberculosis. Sometimes it's thought that moving to a climate that provides more sunshine will help people with tuberculosis. As a nurse, the objective is to control the spread of the infectious agent, promote immunity, strengthen potential recovery in a patient with an infectious disease. Problem statements for nursing diagnosis for our tuberculosis patient may be an altered breathing pattern due to decreased lung capacity, absence of compliance due to lack of knowledge, altered activity tolerance due to fatigue, altered nutrition due to productive cough, anorexia. An airborne infection in addition to standard precautions, also uses isolation precautions. The TB patient uses airborne infection precautions. The patient needs to be placed in a negative pressure isolation room that has an anteroom or a pre-room before actually going into the patient's room. In this room, it allows the caretaker to put on gown, gloves, mask. In the room, because it is a negative pressure room, there is a high efficiency particulate air or HEPA respirator that must be worn because it fits tightly against the face and make sure that the people that are caring for the individual with TB do not become exposed. As nurses, we know that maybe improving living conditions as well as understanding the health practices are essential to maintaining a natural resistance to tuberculosis. The population of individuals that are most at risk for contracting TB are the ones that have an insufficient and immunocompromised immune system. It is feasibly possible for the tubercle bacillus to attack as well as damage parts of our body other than the actual lungs. Considering occupational disorders of the lungs, that is why the occupational history is part of the physical assessment history as well as a respiratory assessment. Sarcoidosis is a multi-system inflammatory disease that is characterized by granulomas, mainly in the lungs and in the intrathoracic lymph nodes. Fibrotic changes cause a reduction in functional lung tissue. A great number of patients, more than 75%, will recover with treatment only for the symptoms. Patients with extrapulmonary or persistent pulmonary disease are treated with corticosteroids. Pulmonary fibrosis will occur from environmental pollutants, some medications, as well as interstitial lung disease that may scar the lungs. Occupational inhalation of lung irritants or smoking and or radiation treatments to the chest are current risk factors. Signs and symptoms of pulmonary fibrosis are exertional dyspnea, a non-productive cough, and inspiratory crackles and sometimes clubbed fingers. Pleuritis may also be known as pleurisy, which is an inflammation of the pleura and most commonly caused by an infection, but can also be caused due to medications, lupus, or rheumatoid arthritis. The treatment for pleuritis is aimed at the underlying cause and to provide pain relief. Lying on the affected side or splinting the affective side during coughing may assist the patient in some relief. The exudate can be thicker and contain cells, proteins, and other substances. Exudative pleural effusion is usually from pleural and lung inflammation, but may also be caused by an organ system through a variety of different mechanisms. Most empyemas are secondary to pneumonia. Treatment will include drainage of the fluid by one or more chest tubes that are attached to a closed drainage system and through the use of antibiotics. A specimen of fluid will be sent for culture and sensitivity, which will help decide the choice of the antibiotics. If the source of the empyema is from pneumonia, The organism that causes the pneumonia is also responsible for the empyema. For bronchiectasis, frequent aspiration of food particles may also cause the condition. In the United States, roughly 1/3 of all bronchiectasis is caused by cystic fibrosis. Lung damage will occur in cystic fibrosis because of excessive secretions of abnormally thick mucus, the impairment of ciliary action within the lungs, airway obstruction, and repeated infections which will cause scarring. Treatment of symptoms may include bronchodilators, expectorants, oral pancreatic enzymes, double doses of fat-soluble vitamins A, D, E, and K, as well as mycolytics. A high-protein, high-calorie, moderate fat diet is also suggested. Kyphosis of the spine or severe scoliosis may hamper lung expansion, but the lung tissue remains normal. Obesity is also becoming a major cause of restrictive lung disease. Obstructive disorders can be caused by cigarette smoking and other inhalation of irritants, chemicals, or particles from air pollution, agricultural chemicals, fumes, or dust. Another factor of obstructive pulmonary disorders may be genetic. COPD describes a condition that includes the related diseases of emphysema and chronic bronchitis. Also related is chronic obstructive asthma. COPD is a chronic disorder treated with bronchodilators and anti-inflammatory agents to remain a stable condition. Reduced exposure to lung irritants such as cooking, fires, smoking, and pollution also helps to prevent further deterioration. Some complementary and alternative therapies are considered ginger and cinnamon for emphysema and chili or garlic as mucolytic agents. Oxygen should be titrated to maintain an oxygen saturation of 88% to 92%. COPD patients have adjusted to chronic hypoxia and to high carbon dioxide levels. The nurse should closely monitor the pulse oximetry readings and titrate the oxygen as necessary. Pulmonary hypertension is high blood pressure in the blood vessels of the lungs. Lung pressures are measured during right heart catheterization using a pulmonary artery catheter. Cor pulmonale is enlargement of the right side of the heart as a complication of pulmonary hypertension that is caused by constriction of the pulmonary vessels in response to hypoxia. To overcome the increased pressure in the lungs, the right side of the heart must pump more forcefully, causing enlargement. Gastroesophageal reflux disease is twice as likely to occur in patients with COPD. It can worsen the symptoms of COPD. The reflux of the acid in the esophagus stimulates bronchoconstriction, and microabsorption may contribute to lung damage. On initial admission assessment of a patient with acute exacerbation of chronic obstructive pulmonary disease, the nurse is likely to expect which sign and symptom: tensing of the shoulder muscles, inability to tolerate sitting up, flaring of the nostrils, completes sentences with no effort, sternal retraction. The answer is 1, 3, and 5. Healthy People 2030 objectives include reducing deaths, hospitalizations, emergency department visits, and activity limitations related to asthma. Unrelieved asthma attacks become status asthmaticus and are very serious. Respiratory distress without wheeze is an ominous sign for the asthma patient. This suggests further constriction with very little air movement. Asthma is a chronic lung disease characterized by reversible airway obstruction, airway edema, or swelling from inflammation, and increased airway hypersensitivity to a variety of stimuli. With asthma, a precipitating factor creates inflammation of the airways. This causes bronchospasm and edema. Cough usually indicates obstruction of larger airways. Dyspnea, another common symptom, is indicative of inflammation of the airways, mucosal edema, and excessive secretion of mucus, which cause a plugging of the small airways. With bronchoconstriction, there is further obstruction and narrowing of the airways, limiting airflow. Asthma patients are taught to use a peak flow meter to determine the drug dosage needed to control the asthma, to predict the effectiveness of therapy, and to detect airflow obstruction buildup before it becomes serious and requires hospitalization. Bronchodilators in the form of beta-adrenergic agonists and inhaled glucocorticoids are mainstays of therapy. Theophylline and anticholinergic agents, such as atrovent, mucolytics, and antibiotics, may also be prescribed. Oxygen is prescribed for moderate and severe hypoxemia. For acute episodes of hypoxemia, oxygen is given to raise the SpO2 to 92% or greater. Systemic glucocorticoids are given for acute episodes. Asthma patients are taught to use a peak flow meter to determine the drug dosage needed to control the asthma, to predict the effectiveness of therapy, and to detect airflow obstruction buildup before it becomes serious and requires hospitalization. Peak flow metering is based on the greatest airflow velocity that can be produced during a forceful expiration that starts from fully inflated lungs. About 15% of men and 22% of women diagnosed with lung cancer survive more than 5 years. The percent is low because often lung cancer is not detected until it is at an advanced stage. Chronic irritation of the epithelial tissue in the lung causes changes in cell structure. This makes the tissue more vulnerable to carcinogens and irritants inhaled when smoking or breathing air that has particulate matter. Non-small cell lung cancer includes adenocarcinoma, squamous cell carcinoma, and large cell carcinoma. This accounts for about 85% of all lung cancers. Non-small cell tumors are usually found in the lung periphery and have undifferentiated cells that have slow growth and tend to metastasize. Small cell lung cancer makes up the other 15%. Small cell or OAT cell tumors grow rapidly and are often located near a major bronchus in the central part of the lung. More specific symptoms depend on the location and size of the malignant tumor and the areas to which it has metastasized. Tumors pressing against the trachea can produce hoarseness and paralysis of the vocal cords. Fatigue, anorexia, and weight loss are common because lung cancer is usually advanced when discovered. Treatment is based on the type of cancer, small cell or non-small cell, and its stage. Surgical procedures can include a wedge resection, where a small area of the lung is removed, a segmental resection, removal of lung tissue and surrounding blood vessels and bronchioles, a lobectomy, removal of an entire lobe of the lung, and pneumonectomy, an entire lung removal. Lobectomy is the most common procedure for small cell lung cancer. Small cell tumors respond drastically to chemotherapy and radiation, but if the disease is extensive, the malignancy tends to recur because of metastasis that occurred before the diagnosis. Pulmonary embolism occurs when a pulmonary vessel is plugged with a mass or clot. Emboli can occur in solid, liquid, or gas forms, and they can occur from a fracture of a long bone, like a fat embolus, from amniotic fluid during childbirth, from air introduced through a central line, or from clots formed somewhere else in the body, like a DVT. Symptoms are respiratory distress with dyspnea, chest pain, cough, hemoptysis, and anxiety. Hypotension, tachycardia, or confusion may occur. A sudden onset of dyspnea and a drop in SpO2 in a patient at risk of thrombus formation is very suggestive of pulmonary embolism. Oxygen therapy is initiated to decrease hypoxia. Treatment depends on the size and the location of the embolus and the stability of the patient. Intravenous heparin is usually begun in patients who might require invasive tests or treatments, or when long-term therapies have not been decided. Stable patients are started on injectable low molecular weight heparin and may be transitioned to oral anticoagulants for a recommended 3 months of treatment. The major complications of chest trauma involve either the lungs and air passages or the heart and major blood vessels, and the patient can deteriorate rapidly. Major concerns in the care of patients with chest injuries for the nurse are maintaining an airway, ensuring adequate ventilation, and treatment of circulatory problems to ensure circulation of oxygenated blood. Pneumothorax and hemothorax often occur as a result of a blunt, non-penetrating, or a penetrating injury to the chest wall. These conditions may cause partial or total collapse of either one or both lungs. The space within the pleural membranes is an airtight compartment with negative pressure. This negative pressure allows for tidal volume of air in and out of the lungs. However, if there is a break in the airtight compartment, either along the surface of the lung or from outside the pleural sac, air will rush in and collapse the lung. Pneumothorax is a threat in chest injury and usually present in the period after thoracic surgery. The condition also may occur spontaneously when there is a rupture of the alveoli. This is called spontaneous pneumothorax. Hemothorax is the presence of blood within the pleural cavity caused by laceration of the lung, heart, or blood vessels within the thorax. The accumulation of blood in the pleural cavity can cause either partial or total collapse of the lung. Pulmonary edema is classified as cardiogenic or non-cardiogenic, depending on the cause. Left ventricular heart failure is a common cause of pulmonary edema. Furosemide is often given for fluid diuresis, and morphine will assist to reduce anxiety and the workload of the heart. Acute respiratory distress syndrome is a form of acute lung injury. When the alveoli capillary membrane is injured, it becomes more permeable to intravascular fluid. Alveoli fill with fluid, and carbon dioxide and oxygen cannot cross the membrane into and out of the capillaries. Pulmonary edema and lung stiffness occur, resulting in severe hypoxemia. There is increasing hypoxemia and respiratory alkalosis from tachypnea. As acute respiratory distress syndrome progresses, symptoms worsen because of increased fluid accumulation and decreased lung compliance. The onset may be as soon as 12 to 48 hours after the initiating event. Treatment for acute respiratory distress syndrome is ventilatory support with low tidal volumes to prevent additional pressure-related lung injury, positive end expiratory pressure, PEEP, or CPAP, treatment of the underlying disorder, careful fluid and electrolyte management, and total care for basic needs. Respiratory failure is the result of insufficient oxygen or excessive carbon dioxide. The disorder can occur acutely or as a chronic condition. Hypoxemic respiratory failure type 1 occurs when the PaO2 oxygen is lower than 60 millimeters of mercury and a normal or low PCO2 is present. This is a result of insufficient oxygen passing from the alveoli to the capillaries. Hypercapnia, also called hypercarbia, is the result of hypoventilation, during which time the usual amount of carbon dioxide is not eliminated by exhalation. In hypercapnic respiratory failure type 2, the PCO2 level is greater than 50 millimeters of mercury. Respiratory failure is treated with oxygen and respiratory therapy that will include mechanical ventilation, non-invasive ventilatory support, measures to reduce and remove secretions, drugs to reduce bronchospasm and airway inflammation, and correction of acidosis. Treatment of the underlying cause is also needed. Intrathoracic surgery, like lung tissue resection or other pulmonary structures, requires opening the chest wall and entering the pleural cavity. An intrathoracic approach is also necessary to repair the heart and great vessels or defects of the esophagus. Preoperative patient education focuses on teaching information to improve the lung ventilation and to prepare for postoperative equipment like chest tubes, suctioning, mechanical ventilation, and the use of an incentive spirometer. During the immediate post-op period, nursing assessment and intervention focus on routine positioning, turning, coughing and deep breathing, procedure-specific observations, and the attention to chest tubes and the closed drainage system. A patient that has had thoracic surgery should be ambulated as soon as possible. Bronchodilators are drugs that act directly on and relax the smooth muscle of the bronchi and thereby relieve bronchospasms. Without adequate water and humidity, mucus secretions become extremely thick and tenacious, and the mucous membranes become dry, crusted, irritated, and more susceptible to invasion by a pathogenic organism. For oxygen delivery of 4 liters per minute or less, humidification is not necessary. Pulmonary hygiene programs include administered prescribed drugs, humidifying inhaled air, medication therapy via the nebulizer, DPI or MDI, chest physiotherapy, and breathing exercises. Chest physiotherapy includes postural draining when possible and percussion and vibration. Postural drainage involves positioning the patient so that the force of gravity can help remove secretions deep in the bronchi and the lungs. Oxygen is considered a medication or a drug, and it must be prescribed and administered in specific doses to avoid oxygen toxicity. The dosage of oxygen is stated in terms of concentration and flow rate. Methods of administration are divided into high flow and low flow systems. Low flow systems supplement oxygen needs, but do not deliver the total amount of oxygen needed by the body. Room air contains 21% oxygen. Every liter of 100% oxygen delivered increases the FiO2, the fraction of inspired oxygen, by 3%. The amount of oxygen the patient receives depends on the rate and the depth of breathing. A nasal cannula provides a low flow and should not exceed 5 liters per minute of flow. High flow rates cause drying and cracking of nasal mucosa. If a mask system is used, it is important that the flow rate through the mask is at a minimum of 6 liters. Lesser flow rates are not adequate to wash out the exhaled carbon dioxide and will cause the patient to rebreathe the exhaled carbon dioxide. High flow oxygen delivery systems provide oxygen levels high enough to completely supply the needs of the patient. They do not rely on the patient's breathing to provide the set amount of oxygen. For prolonged periods of high percentage oxygen delivery, the oxygen should be humidified. High flow oxygen therapy provides humidified oxygen from the source to the high flow machine. There are 3 major areas of assessment with a chest tube: the respiratory status of the patient, the site where the tube is inserted into the chest and the length of the tube, looking for any kinks or clots, the amount and character of the drainage in the collection chamber. The patient is assessed for ease of breathing, pain or discomfort, level of consciousness and orientation, and anxiety and restlessness. The rate and character of respirations are noted, as are the breath sounds. The entry site is assessed for usual drainage, infection, integrity of sutures, and the presence of subcutaneous emphysema. The chest tube will be attached to a drainage system. The drainage system should provide for drainage of air and blood from within the pleural cavity and allow for gradual re-expansion of the lung by isolating the intrathoracic pressure from the atmospheric pressure. Note that the water in the left-hand chamber serves as a suction control chamber. When the unit is attached to wall suction, there will be bubbling in the compartment. The level of fluid determines the amount of suction applied to the chest. Increasing the wall suction will increase the bubbling, but does not change the degree of suction. Slow, gentle suction is adequate. The middle chamber is the water-sealed chamber that prevents air from entering the chest cavity. Titling, or movement with breathing, should occur in the middle chamber. If air is being removed from the chest, bubbles might be observed in this chamber. The collection chamber, located at the far right of the chamber device, is calibrated for accurate measurement of drainage from the chest. Remember that the pleural cavity is an airtight compartment. The apparatus and all connections must remain airtight at all times, and all connections should be taped. When working with chest tubes and a drainage system, nurses should not allow the tubing to become kinked or obstructed by the weight of the patient. The tubing should never be pinned to the bed clothing. Empty chest tube drainage systems are not emptied. The system has to remain closed. The unit will be replaced when the drainage chamber is full. The drainage system operates by gravity and must remain below the patient's chest level at all times. The amount of drainage expected will vary according to why the chest tube was inserted. Discover from the physician how much drainage should be expected and when to call the physician. If the chest tube becomes unattached, do not clamp the tube. Place the end of the tubing in a container of sterile water. This creates a water seal and can prevent tension pneumothorax. Temporary clamping may be performed by the surgeon to assess lung function or occasionally by the registered nurse to check for the source of air leaks. Persistent bubbling in the water seal chamber indicates an air leak. Fluid in the chamber should fluctuate with inhalation and exhalation. Occasional bubbles may appear with breathing, sneezing, or coughing. If a pneumothorax is present, bubbling will occur with inspiration, as air is forced out of the area of the pneumothorax. A puffed up appearance of the patient's chest or neck could be a subcutaneous emphysema. Dressings on the tubing should be reinforced but are not changed except by an order of the surgeon. Dressings must be occlusive and not allow air in around the site of the chest tube. Mechanical ventilation is needed when the patient cannot maintain adequate ventilation because of respiratory, neurologic, or neuromuscular problems or trauma. In the acute care setting, the most commonly used method is positive pressure ventilation. The pressure delivered is greater than that within the airway and the alveoli. Gas flows into the lungs, either assisting or controlling inhalation. When the pressure is released, exhalation is passive without effort by the patient or the machine. In controlled mode ventilation, the machine is set to deliver a fixed number of breaths per minute at a set volume. The machine does not allow for spontaneous respirations. Controlled ventilation is used during periods of central nervous system depression, like during anesthesia, sedation, or a drug overdose. Assist mode ventilation decreases the work of breathing for the patient. When the patient takes a breath, the machine delivers a set tidal volume. Assist mode ventilation is combined with control function to provide an assist control mode. If the patient's respiratory rate falls, the machine will deliver a set number of breaths per minute. If the patient initiates a breath, the machine finishes it at the set tidal volume. The patient can breathe above the set rate on the ventilator. Intermittent mandatory ventilation and synchronized intermittent mandatory ventilation are the most common modes of ventilation found in critical care settings. These allow the patient to breathe spontaneously and yet provide a preset number of ventilator breaths at a preset tidal volume. This will ensure adequate ventilation without respiratory muscle fatigue. The prevention of ventilator-associated pneumonia includes multiple nursing interventions. The nurse auscultates the lung fields to be certain that both lungs are being ventilated. The nurse will monitor the ABG levels to determine the effectiveness of the ventilation treatment. Use of a ventilator bundle helps prevent ventilator-acquired pneumonia. The Agency for Healthcare Research and Quality recommends regular oral care with chlorhexidine, continuous removal of subglottis secretions, change of ventilator circuit only if visibly soiled or malfunctioning, select oral and digestive decontamination, and prophylactic probiotics.